you. So I do have the longest title for a PhD project. I'm quite proud of that. And I've made it a bit shorter for today. So my PhD research is about patients with COPD, understanding how we provide palliative care to these patients and looking at a new model of care. So chronic obstructive pulmonary disease is an incurable, non-malignant progressive respiratory illness which is characterized by respiratory failure and by airway obstruction. It generates a huge disease burden both globally and within Australia. So in Australia, about 29% of people over the age of 75 years have COPD, and that translates to about 320,000 people, but we know that that's an underestimate because that's self-reported disease. So it's actually probably 3 times as high. So we're probably talking about 1 million people in Australia have this condition. It's the 5th leading cause of death, accounting for about 6,500 deaths per year. And we know from some lovely work that Jenny Phillip and the team did in here that about 3/4 of COPD patients die in hospital. And that's despite the fact that we know most people say they want to die at home. Not only does it cause a lot of mortality, it causes a lot of morbidity. So nearly everybody who I see has breathlessness, and that's distressing breathlessness. We also know that despite treating all the reversible causes for breathlessness, many of these patients have persistent refractory breathlessness, and that refractory breathlessness by definition is very difficult to treat. We know that as clinicians we often underestimate the severity of that breathlessness. You have to ask very specific questions and really drill down to ask about breathlessness. But we also know that patients can underestimate their breathlessness. COPD is a highly stigmatized disease, unfortunately. It's smoking related, and patients often feel guilty about telling us about how breathless they are because it's smoking related. Not only do they have a lot of symptoms, these patients unfortunately often don't understand how severe their disease is and what the prognosis is. So if I say to someone they've got lung cancer, they usually understand quite quickly that I'm saying they're going to die, and they've got a very good idea about how quickly that might happen. If I say to someone they've got COPD, they smile and wander off because they don't really understand that it's a life-threatening illness and it will limit their life. So it's a difficult disease to manage. These patients also have high use of healthcare services. So this is data from a few years ago that says we spend a lot of money. We probably now spend $1 billion a year in looking after these patients in direct healthcare costs alone. So as everybody knows, palliative care is a different approach. It's an approach which aims to improve the quality of life of patients and their families when dealing with a life-limiting illness. And that occurs by trying to deal with physical issues, such as symptoms, spiritual issues, and psychological issues. So it's trying to deal with many different complex problems that a family or a patient might face. I think it's important to remember, though, that whilst the community and often many health professionals think of palliative care as end-of-life care, as all of us know, it's actually applicable early in the course of an illness. And that's something I want to talk about a bit more. It's also important to remember that specialist palliative care has only existed for a short period of time and really grew out of the British hospice movement in the 1960s. Palliative care has only been recognised as its own specialty in the last 30 years. And that means there's an awful lot of people who provide palliative care who are not specialist palliative care clinicians. That therefore means it's the GPs and the usual care providers who need to be able to provide palliative care and recognise when it's needed for the vast majority of people, and particularly the vast majority of our COPD patients. So palliative care sounds good and is good. It improves symptom control, it reduces anxiety, leads to less aggressive treatment. There's some evidence that it improves survival and it reduces healthcare costs. So because it's well recognised to have so many benefits, even respiratory physicians like myself now recognise that palliative care has a role for our patients. And in fact, the American Thoracic Society, which is one of the peak societies in the world for respiratory medicine, put out some guidelines in 2009. And they're very comprehensive guidelines, actually. But what's quite important is they came up with 11 key points. And I just want to focus on 2 of these, and that is that all patients, once they become symptomatic, need palliative care, or should have palliative care considered for them, and that this should occur concurrently with active life-prolonging care, which is not what usually occurs. So we recognise palliative care is applicable to our patients with COPD But sadly, the reality seems to be from the literature that very few patients access palliative care. The latest Australian Institute of Health and Welfare data shows that only 2.6% of all palliative care admissions are for patients with COPD. And maybe that's just because these patients don't come into hospital. So some data from Western Australia has looked at access to palliative care for COPD patients in their last year of life. And that study's a nice study. It's been repeated 10 years on. And what they found is not many patients access palliative care in their last year of life. It's improved a bit in 10 years, but we're still talking about only 18% of these patients. And yet we know that their symptom burden is the same, if not higher, than lung cancer patients who easily access palliative care. So why don't we palliate these patients? Why don't I do it? Why don't my colleagues do it? Why don't we refer on? Well, it's tricky really. The main one is probably lack of time. If I've got to see 15 people in a clinic and they've all got multiple issues, I'm probably not going to talk about palliative care. It takes time, it takes multiple conversations, as we all know, to talk about palliative care, and you usually need to feel confident talking about it, which an awful lot of health professionals don't feel. It's also important to remember that if I say palliative care, most people look at me and think I've got two heads, because they think that's not applicable to me. I'm not dying. I'm not at the end of life, and I don't have cancer. So it can be very challenging to raise this issue of palliative care with a group of patients and their carers who don't recognise this as being something that's appropriate for them. And the other issue is that it is actually very difficult for this particular disease to make an accurate prognosis. I think most of us are familiar with these disease trajectories, but if I see someone with cancer, I can be fairly sure once they're fully staged what their prognosis is likely to be, and that they'll probably progress and deteriorate quite quickly. When I see someone with COPD, it is a very slow progression. I have patients who have severe lung disease, who are oxygen dependent, who've been seeing me for 10 years. And they probably should have died some time ago. If I looked at the predictors of death, we would have said they would have died within a year, and they're still with us and they're stable. So that decline is very slow over many years, and the patients don't see it, their families don't see it, and we often fail to see it as well. In addition to having a slow decline, they often have these intercurrent exacerbations, and we make them better. So patients see that we've made them better each time. So it's difficult to say, well, the next one might be your last, because they will say, but you made me better. So we're almost a victim of our own success. So given that we know these patients would benefit from some palliative care and they don't access palliative care, how do we move forward? Well, we move forward probably by having a new model of integrated respiratory and palliative care. Hence why a respiratory physician gets talked at Palliative Care Forum, which is marvellous. So it's interesting because we recognise this model is actually occurring in a few different sites, but only 3 sites in the world have published their data to date. And all 3 sites have shown the same thing, that their services have improved quality of life for the patients and carers that they have worked with. All of the 3 services that have published are completely different. So the Breathlessness service in Cambridge is run by Palliative Care, and they only see patients once or twice. The Inspired model of care, which is in one part of Canada, is long-term care offered by respiratory physicians, and they cover a huge area of Canada, a bit like Australia. They cover a huge remote area, and they've showed reduced healthcare costs and reduced admissions. The Breathlessness Support Service in London is interesting. So they just did a randomised control trial to show the efficacy of their service, and they published that data in 2014. And they showed that not only did they improve quality of life, they improved disease mastery, they actually showed improved survival, which was quite an unusual and unexpected finding. And because it's a small study, it probably needs to be explored more. And then there's my own service, the Advanced Lung Disease Service, which I'd like to tell you more about. So this is a service that I set up 3 years ago at the Royal Melbourne Hospital, and this is very much a partnership between respiratory medicine, palliative care, and now the emergency department have kindly become part of the team. And the whole aim of our service is that palliative care is provided by the usual care provider in a very specialised clinic for patients with severe or very severe non-malignant lung disease. And so that usual care provider is me, the respiratory physician. And the way we have it is we have palliative care in the clinic, so I have a palliative care registrar and a consultant, but I only use them when I need to use them. So most of it can be provided by the usual care provider, but by having palliative care embedded in the clinic, we have very easy access, and also the patients do recognise that these people do not have two heads. They're not the Grim Reaper as I showed in my last slide. They're nice, normal people, and they become very acceptable for the patients to continue to see. The way we run the service, we have a multidisciplinary team meeting on a monthly basis, and we have a multidisciplinary clinic every week, and we have extended consultations because we try to get through a lot in a consultation. And we provide long-term care, which is actually very tricky. So we try to see people until the point of death, but obviously when they get too unwell to see us, then we do a lot of distance consulting, and we provide a lot of support to the GPs and local care providers. I'm very lucky. I have a fabulous nursing team that works with me that does a lot of community outreach and telephone support, and that's pretty much how this model of care works. So the key things we do all the usual respiratory stuff, but very much the focus of a lot of my work is symptom management and dealing with very difficult breathlessness. The other key focus is on advanced care planning and trying to support other healthcare professionals, because I can't see everybody in the state, but I can help other people to look after these very difficult, complex patients. And obviously our key aim is to be able to access specialist palliative care when these patients need it and to make it acceptable to them. So the research question for my PhD is how do patients with COPD access palliative care? And can this new model of palliative care make a difference? So my project has 3 different phases, and I'm only going to talk to you about 2 of them because otherwise I'll be talking all night. So the 2 phases I'm going to talk about are the Cohort study, which is looking at what we've done or have been doing up until recently in providing palliative care, and the model of, then the second phase of looking at the model of care and whether it's effective. The third phase has actually been a survey exploring attitudes to providing palliative care and symptom management, and that's actually completed, but for time's sake I won't tell you, but just to give you a brief idea, that's been a survey of 3,000 doctors in New Zealand, Australia and the UK to assess their attitudes to prescribing opioids, breathlessness and palliative care for COPD patients. And we got 1,000 responses, which wasn't bad for an online survey, and that data is being analysed. So to talk a bit about the Cohort study, so this first phase is very much about looking at what happens when someone comes into hospital and dies. So the exacerbation that they thought they wouldn't die from, but they do die from, what happens? Do we palliate them? Do we continue to treat them right until the moment of death? How do we care for these people during that terminal admission? And what have we done in the 2 years beforehand for those patients? So that study has been conducted at 2 hospitals, the Royal Melbourne Hospital and North East Health Wangaratta. We've used 2 sites so that we can compare and look at how if and how there are regional differences in how we provide palliative care. So to give you a bit of information about that study, so we've looked at all patient deaths over 12 years, and we've only looked at people who died from COPD. So if you died from your heart attack but you had COPD, you're out. But if you died from your COPD, you're in, because we really want to see how do we palliate people who are dying from COPD. We exclude people who have cancer because we know that's a group that traditionally accesses palliative care well, so we don't want to muddy the water here. And we've really looked in detail about what sort of preventive treatments did these patients have. Were these people dying on osteoporosis treatment? Were they receiving antibiotics? And did they get any sort of treatments for palliation of symptoms at the end of life? So that study is well underway. We've pretty much collected nearly all the data from the Royal Melbourne Hospital. Had a few issues with ethics at North East Health Wangaratta that took us 9 months to sort out, but data collection is now well underway. And I've got some preliminary findings that I want to show you, and these findings were I presented them at a conference earlier this year, and I'm about to take them to London to present them to a European respiratory conference. So to give you an idea, so this is data from the first 10 years of deaths just at the Royal Melbourne Hospital. Of the 226 that we had at that time, we only included 165. So the exclusions are because they either had cancer, their file was missing, or they didn't die from COPD. So it's an older age group of patients. On average, they're about 80 years old. I didn't mean to do that. And 2/3 of them are male, which is fairly representative of COPD patients. Most of them are, about half of them are oxygen dependent. And because I'm a respiratory physician, I have to show you lung function data, and they've all got severely reduced lung function. So this is not a great surprise. These patients have severe lung disease. They're oxygen dependent. The MMRC breathlessness score is the Modified Medical Research Council breathlessness score. It's a very well validated tool in COPD, and it's been around since the 1950s. 0 is normal and 4 is very severe COPD, so you're housebound or you get breathless when you get undressed. So when we looked back and calculated what these patients' breathlessness scores were before that terminal admission, the average score was 3, so they all had very severe breathlessness. 76 of the patients had had previous outpatient visits with the Royal Melbourne Hospital, and on average had 3 visits. And 94 of those patients had had hospital admissions with us previously, and on average they'd had 1 hospital admission. Now, as you can see from this slide, so this slide shows you what treatments they got on admission and what they got at the time of death, and that's 4 days. So from admission to death is 4 days. So when they first come into hospital, most of them are getting antibiotics and steroids and nebulizers, which is the standard treatment for an exacerbation of COPD. But as you can see from the red bars, at the point of death, many of these patients, half to 2/3, we've actually stopped active treatment, but there's still a proportion where active treatment continues until death. Sadly, quite a few of these patients seem to be on long-term prophylaxis at the time of death, and I think that's kind of rather strange while we're giving someone osteoporosis treatment at the moment of death, but there you go. So there's some inappropriate treatment, but what's very pleasing to see is how many patients are receiving palliative treatments or treatments for palliation of symptoms like breathlessness or pain or anxiety or distress at the end of life. So looking at that, just the opioid data, this is opioids for breathlessness and pain. When these patients come into hospital, about 82% of those patients are receiving opioids for some reason to palliate symptoms at the end of life, and the average dose that we've used is between 8 to 15 milligrams, which is similar to the amount that I would use to treat someone with refractory breathlessness. What's quite interesting is if you looked for the 2 years beforehand, only 11 of all those patients, only 7% had been given any opioids to treat their refractory breathlessness. And yet I showed you before that most of them were extremely breathless before they came to hospital. And this is also very interesting data looking at advanced care planning. When we look at what had happened in the 2 years before, you can see only 22 patients had discussed in the 2 years before their death any advanced care planning, and only 11 had completed an advanced directive. So we had 2 years where we could have done something for quite a lot of people, and we didn't do it. However, that said, at the time of death, the goal of treatment as being to palliate the person at the end of life was documented, which we actually didn't expect to find it as being that high. This slide just gives you a bit of a snapshot of what happened. So as I've said, it's 4 days. We recognise halfway through that the patient isn't getting better, they look like they're going to die, send them to palliative care, start palliating. But interestingly, we're still giving a lot of active treatment in that time phase. Is that a problem? Probably not, because the patients might want it and the family might want it. So if it's not burdensome, it's probably not a problem. But I think the key to come away from that phase is that we probably had a lot of missed opportunities in the 2 years beforehand. We probably did reasonably well at the terminal admission, but we missed opportunities in the 2 years beforehand. I just want to briefly tell you about the audit of the Advanced Lung Disease Service. There are a lot of aims on this slide, and all I want to tell you is that we're trying to see if the service works. And the thing that we've actually just started doing, or at least I'm just trying to get an ethics clearance for, is to survey the patients and the carers to see if they like the service. So that's in progress at the moment. But so this is basically a clinical audit. So we have a research database, I have a research database for my patients in the Advanced Lung Disease Service, which has existed for 3 years. We've seen over 200 patients, but we've had about 170 that we prospectively collect data on, and we've looked at that data retrospectively now. And so the average person who comes to see me is about 75 years old, and again, more than half are male. Most of these patients have COPD, but I do see people with other respiratory illnesses. And as you can see, this is a complex group of patients. On average, they have 6 other medical conditions. And most of them don't just have one respiratory illness, they have multiple respiratory illnesses. They all have severely reduced lung function. And a third have anxiety and a third have depression. So they have high psychological needs as well. And again, a lot of them are oxygen dependent, and this group have very severe breathlessness with a breathlessness score of 4. I just want to point out that, unsurprisingly, about a third of these patients are now dead, which again, it shows we're seeing this very severe group. I hope that doesn't reflect my care. the length of follow-up that we usually see these people for is about a year. So just to show you a few key findings from this. If you don't ask, you don't get. Now, I showed you in that previous study that only 33 people had done any advanced care planning. With our service, we ask every single person, can we have the conversation? Now, not everyone will say yes, and that's their absolute right, but 89% of people have agreed to have a conversation with us, and I should say multiple conversations, because obviously this occurs over many, many conversations where we talk about what their needs are, their wishes are, for now, the future, and obviously it constantly changes. I've had people write advance directives to then completely overturn them, and they can generate a huge amount of anxiety. I don't think it's a problem that a lot of people don't want to write an advance directive. A lot of people actually just want to have a conversation, but are happy for us to document what their wishes are, and at least we've sowed the seed so that if they come into hospital, they're not going to get a big surprise if they're not going to get better. Just a couple more slides I want to show you. This is data that shows what happened before they came to us and then since being with us. And as you can see from this slide, we've had reduced hospital admissions and reduced admissions for a respiratory illness after they've been seeing us in that first year. Now this is quite important because we would expect this to go the other way, because these are people who by and large are in the last year of life, and we know in the last year of life that's when you have the highest healthcare utilisation. No surprise, because they're part of this service, these patients have very good access now to specialist palliative care, and that comes in many different forms, community palliative care or a palliative care specialist in the clinic. But it's also worth remembering not everybody wants to see palliative care, and some patients have declined seeing them, even though they don't have two heads. And lastly, and this is probably my key slide because I think this is so important, again, if you don't ask, you don't get. As I said before, about 3/4 of patients in Victoria die in an acute hospital bed from their COPD. With our service, we actually only have 22% of patients are dying in an acute hospital bed. And I think that's fabulous because now more of these patients are able to die at home, die in their nursing home, or some of them die in community palliative care or hospital palliative care. Is it just changing semantics from hospital palliative care to from an acute bed? Not really. We're talking about freeing up access to acute hospital beds, so I think it's extremely important that we're changing this place of death. So from the data I've shown you, and I haven't shown you all of it, I've just given you a snapshot, I think we can say that this new model of care improves access to specialist palliative care, and it certainly improves those opportunities for communication and advanced care planning. And on that note, I'm going to end. I have a lot of acknowledgements to make. I have to acknowledge Palliative Care Research Network and say thank you very much for my scholarship. I wouldn't be able to do all this work if I didn't have it. And I have to acknowledge Jenny, Philip and Terry O'Brien, who are my fabulous supervisors. And I have a very large team of people who I work with, both in the Advanced Lung Disease Service and a variety of collaborators in 3 different countries who've helped support doing some of these surveys and other projects. So I'd like to acknowledge all of them and thank them. Thank you.
Thank you, Natasha, for an outstanding presentation. Certainly value for money in your PhD. Does anyone have any questions in the audience?
The survey you did of the 3,000 GPs and 1,000 responses you got back, what was the overriding attitude toward prescribing opioids?
So the question is, of the survey we did, what was the attitude towards prescribing opioids? So I actually should clarify, the survey we did was we surveyed palliative care and respiratory medicine specialists and doctors in training, and we surveyed junior doctors in Victoria. And so for some of those groups we surveyed in 3 countries, and we surveyed just junior doctors in Victoria. And the GP survey is underway. So we've actually got, we've only got 33 responses because we're a very hard group to survey, but we're actually surveying Victorian GPs at the moment. The response to opioids is really interesting, and what we were most interested in was, is there a big difference between respiratory medicine and palliative medicine in our attitudes to prescribing opioids? And unsurprisingly, there's a huge difference. So most of my colleagues are extremely reluctant to prescribe opioids. But that said, about 50% of them were willing to consider it. But what's interesting is most of them actually don't have the experience of having prescribed, whereas about 70% of palliative care physicians were, totally willing and had experience in prescribing. The junior doctors were very interesting as well. So it was almost slightly frightening that all of them were very willing to prescribe an addictive drug which has serious side effects and never see someone ever again. And most of them had done it without any supervision from a consultant. So that survey, that data has been extremely alarming and tells us that, like everything, you get swings in life. And because there is a lot of publicity about prescribing opioids for this group of patients now, we're almost swinging the other way. And swinging is good, but we need a happy medium, and we need to just be careful about encouraging people to do something that actually could be quite dangerous.
Peter.
Just wondering your reflections. So in the context of cancer, palliative care, the rhetoric is that as soon as someone's diagnosed with advanced cancer, then theoretically the discussion of palliative care should be considered. Also, in the environment, as you well know, there's sort of the barriers to actually getting patients, this cohort of patients, COPD patients seen by specialist palliative care services at the moment, is from a sense of how long has this patient got to live and how they've got resources to look after someone for potentially 7 years or more. And my question is, with that background, what's your sense of when palliative care should be introduced to a patient with COPD? I know it's contextualised and it is based on need. There's been work done around the uncertain bias question, which is 12 months. What's your sense of perhaps best practice based on, I know you explore some thesis, but I appreciate your perspective on that.
So the question is, when should we have these conversations about palliative care with COPD patients? And it's such a difficult question because it does have to be so individualised. And I think one of the difficulties is it is so important to have a relationship with someone. And I find it very difficult to have that conversation with somebody I've only just met. And I find it very difficult with the idea that we send them off to palliative care to have the conversation. I actually recently read a book which talked about that the purpose of palliative care was that you guys had the conversation and we could shoot the messenger, which I definitely don't believe in. I think that discussion needs to be had by the person who knows them best. I think it's very difficult. I mean, people have looked at various different things. There's the use of the surprise question. There are numerous things, clinical predictors that we use in terms of lung function severity, being on home oxygen, ever needing non-invasive ventilation, ever having a hospital admission. So people come up with these red flags of you really ought to have the conversation now, but we actually know that still doesn't happen. So should it be if they come to hospital, if they come to a hospital clinic that we plan to have it, should that be our automatic, everybody who walks in the door, we have a conversation with you as an outpatient? Because it seems to occur as an inpatient when they look like they might die, but we almost need to have it as soon as you come to see us, a specialist clinic, should we have this conversation? If you come to our general respiratory clinic because you've got COPD, should we start to have this conversation? I don't know is the answer, because everybody is so different. I've certainly made the mistake of having the conversation with somebody who keeps saying to me, I've outlived you. You told me I wouldn't live that long. And I'm really pleased she's outlived me. It's fabulous. But it is really difficult because, people lose faith in you and they lose that trust in you. And you're talking about something they don't relate to. So until the concept of palliative care changes, I think it will continue to happen too late. Whilst people think of palliative care as end-of-life care, death care, people that you don't come back from, it will occur too late. If we can say, no, this is about semantics, changing names, this is supportive care, then we have a greater chance of being able to have that conversation much earlier, like the first time they come to see us. But it's a very difficult question.
Is it linked in with when you start having the conversation about advanced care plans?
Is
the discussion about palliative care?
Okay, so the question is the discussion about palliative care linked in with having advanced care planning? Absolutely, because I think advanced care planning, one of the definitions is that you actually talk about the future wishes and palliative care. So in my mind, yes, but I think if you surveyed a lot of health professionals, particularly if you surveyed doctors, because we don't necessarily think as broadly as everybody else, we would all think that an advanced directive is a not-for-treatment order. And of course it's not. It is so much more than that. But a lot of people get hung up on the do not resuscitate order is what an advanced directive is. But of course it should be both.
Okay, we've got time for 2 more questions. Rosalie, then Beth.
Following up from Peter's question, given the very high proportion of people with COPD in nursing homes, would your research have any possibility of making recommendations for the recognition of COPD as a terminal incurable disease, and therefore the applicability of palliative care from the date of admission to residential aged care. I suspect that many of those people will be in high residential aged care for 2 years prior to their death. Therefore, they fit all of your research. But in my experience, it's not readily recognised as a terminal illness and therefore not treated.
So the question is, what's the applicability of this research to nursing home inhabitants? And it's such a good question. So actually, a lot of people who come to see me are from nursing homes, and some of them are from fabulous nursing homes, and obviously there's always a variation in all healthcare services. We do an awful lot of work with nursing homes. So to put into context, I spent an hour yesterday lunchtime doing a teleconference with a GP, about 5 different staff from the nursing home, and a palliative care consultant and a respiratory nurse specialist, because we were having quite a few challenges. She's a challenging patient, she's got a challenging daughter, and the poor old nursing home is pretty challenged and she's trying to die. So the way we can apply this research is really supporting other people. So we want to see people long term if we can, but when we can't, we have to be there to support those people. Now, I'm not funded to go and meet people in the community, but my respiratory nurse is, and often palliative care has funding for community support. And I think it's quite key that if we have these lovely partnerships, collaborative partnerships, that we share our knowledge and resources and take it into the community, whether it's supporting people in nursing homes or GPs. One of the reasons we're surveying GPs is, again, I'm very keen to get some sort of education to the GPs to support them. And one of the things we've had is when someone's gone into a nursing home, often community palliative care won't take them, and we are very dependent on the knowledge and skills in palliative care of that GP. And some of them are fabulous, there's no doubt, but others will hold their hands at a distance and say, you sort it out, and that's where we can provide the expertise. But we need to find a way to have a greater reach, because it is a huge need, and unless we say things like, don't transfer the patient, let her die, let her be peaceful, it doesn't happen. So having those clear directives, which we try to give as much as possible, and communication is the key. So I often pick up the phone and talk to the GP at the end of every consultation. And communication is the key to get this message about how we care for these patients long term. And Beth, lucky last.
Thank you. Great work.
Thank you.
The beginning of revolution for therapy patients here. I'm just wondering, I noticed in the study of current practice that the patients had an average of 1 admission in the previous 2 years, which is surprising to me, and I imagine that in that population there's a subpopulation of frequent flyers, frequent admissions, and there's a subpopulation of people who are maybe belonging to another health service, or maybe they're just not coming to hospital. Hence their first admission is their total one. So I'm just wondering, in your clinic, whether in terms of defining the intervention that you're providing, have you defined the triggers for referral to your clinic? Because maybe you're seeing that subset of the people who are frequent flyers who will then refer to you. And I'm wondering if you've defined the intervention in the clinic, because seeing you with your additional training in palliative care and your interests and expertise is not the same as seeing any respiratory physician, and I'm wondering which patients are treated to see the palliative care specialist that sits in that clinic, and how you're defining the intervention. Yeah. Sorry.
Thank you for that question, Beth. So Beth is asking, firstly, how do patients get referred to us? How do we triage them? And what do we do in a way, and how do we define who they see? The first point to address is your comment about only 1 admission on average. So, if you're an RMH patient, you're an RMH patient. But equally, I know that a lot of these patients might go and have an admission in private, or they've had an admission at St B's or somewhere else. So, because our ethics clearance is limited, and because big data sharing actually is quite complex with the matching, we only know about where they've admitted to our hospital. So that, in my mind, is a complete underestimate, that they've had the minimum of, on average, 1 admission. It is probably much more than that. And certainly if you look at the extended literature in this area, it would be very rare to see a patient who suddenly pitches up for the first time and dies. So that's to explain that. in terms of who gets referred, how do we triage? One of the things we were quite careful, or I was a bit nervous about doing, was ever telling anybody that we existed. Because if you tell someone you exist, you rapidly become overwhelmed and you can no longer deal with your referrals. And given we see people for a long period of time, we have rapid access, we have extended consultations, we didn't want to topple because we were just so fabulous and so highly sought. So as I've said, we've seen about 200 patients, but we've never told the GPs that we exist. And in fact, until recently, I never told the rest of general medicine that I exist. It's purely that we're a moderately large respiratory unit now, and one of the first things we did was we moved all our patients from the general respiratory clinic out. So my first 100 patients came from our general clinic, where we had nothing. We did nothing for them other than manage their respiratory disease. But in our general respiratory clinic, I have 15 patients booked in a morning. So you're lucky if I say hello to you before I throw you out the door. So we never dream of doing any palliative care. So we decanted out of that clinic and knew that these patients needed better care. We then also take a lot of patients from heart, and as it happens, I happen to be the heart respiratory physician at the Royal Melbourne, so I can push all these patients through once they're discharged. And now we take referrals from general medicine, and which has been helped by doing a grand round and telling them that we exist. And I actually also take a lot of referrals from private respiratory physicians, which is quite interesting because they're seeing a lot of people and they don't have time to have a conversation, so they send them to me to have the conversation but send them back to them in private. So we take quite actually a nebulous group of patients and now actually end up seeing people from around the state, which is why it's quite important to give them back and to share that knowledge with other people. So we don't have any set referral criteria. Usually the ones that come from respiratory, someone will just discuss it with me and say, they're pretty complex, will you sort them out? And I'll say, yeah, sure, no problem. Or often it's triggered by the fact they've had an admission. Not necessarily a frequent flyer. We actually recognise that any of them, if they've got severe disease and they've been sick enough to come in, most of them will actually now come my way. Particularly also because I actually send a lot of patients for transplant consideration as well. So we don't have any set referral criteria. Perhaps once the GPs find out we exist, we will. We will have to be more meticulous about how we define which group of patients we take, but we don't limit it. And you're right, it is a bit artificial. I'm not a usual respiratory physician. I do have a very clear interest in palliative care. But the thing that I keep trying to tell my own specialty group is we can all do this. Palliative care is amazing. It's fabulous, but there aren't enough palliative care physicians. We have to do this ourselves, just like the GPs. We have to upskill. The patients want it from us. We have to be able to provide it long term. So I would like to see in the Thoracic Society, and I'm trying to get it to happen, a palliative care SIG in the Thoracic Society of Australia and New Zealand as the next step, so that more respiratory physicians can do what I do. You don't have to dual train. I don't think you even need to do a specialist certificate. You just have to be able to talk to people in care and like getting given a lot of chocolate as well. That's what I would say. So,
I'd just like to thank Natasha for her fantastic presentation. It's a little gift from the PCRN for you.
Thank you.
And I'd like you to join me in thanking both of our fantastic speakers this evening. For those of you who don't need to rush off, I invite you to have some drinks and nibbles just across the corridor, I think. Yes, I'm getting the nod from Alfie. And thank you once again for supporting the PCRN's forum. Thank you.